Can I get a thumbs up from someone in the back if you can hear me okay? Awesome. Hi, everybody. It's great to see everyone. I have not been back at Barnes for a while. I won't say maybe trapped is the right word, but I am over at the VA. It's good to see everyone's face. Excited to do CPC today with the fantastic Dr. Thakker on this beautiful Friday, September the 26th. We'll go ahead and kind of do introductions to start off with. Dr. Thakker really doesn't need an introduction, but currently he's an assistant professor of medicine. He's the program director for the cardiology fellowship, so I am going to take it a little bit easy on him today. He's also the associate director for the interventional cardiology fellowship. He's originally from Ohio, went to medical school at Northeast Ohio Medical University, residency at Case Western in Cleveland, and then came to WashU for cardiology fellowship and interventional cardiology fellowship. And since he's been here, has had a really big impact on learners of all levels, medical students, residents, and fellows. And many of us have benefited from him as a teacher over the past several years. So really appreciate him being here. And if there's anything else you'd like to add to your introduction.
Sorry, you were way too kind. No, thank you so much. It's absolutely been a pleasure. You know, Harrison was my resident on Cart's firm, and I honestly learned more from him than I already knew. So it's always good to be around individuals who elevate you, and that's what our institution's all about, our division and department. So you should be proud of where you are. And as interview season starts, a little plug for Stephen here. Please be engaged and involved, and bring the next generation of learners here and help them grow and help them benefit like you have. So that's all I have to say. So thank you.
Okay. Get into our one-liner. We have a 29-year-old with past medical history of polysubstance abuse, hypogonadism, and diabetes who presents with shortness of breath and weight gain. And we'll kind of pause there and see if you have any initial thoughts about
Yeah, when you first sent me the one-liner, Harrison, I was like, okay, is he confusing me for an endocrinologist? Because I'm an interventionalist, you know. This doesn't sound like a STEMI. I'm not getting activated at night, but this is interesting, right? As you think through things, right, when you see this one-liner, you see shortness of breath, you see weight gain. 29-year-old, okay, I'm going to anchor on the fact that I do cardiology. And I say, okay, well, someone is short of breath, someone's having weight gain. The first thing I'm thinking about is pump function, right? Does this patient have heart failure? And what could be the potential etiologies of heart failure in a 29-year-old who's presenting with polysubstance abuse, hypogonadism, and diabetes? We'll talk a little bit more about that. As I think about the etiology of shortness of breath, again, thinking about from a cardiac perspective, pump failure, are they having orthopnea? Are they having PND? Are there signs of volume overload? I'm thinking about all these questions that I'm going to ask the patient because I know I have a lot of learners here. I have a lot of med students and clerkship students. So let's walk through this, right? We do a thorough review of system based on our differential, right? Are we thinking is this a pump failure? Is this diastolic dysfunction, which again, unlikely but possible if you're thinking about infiltrative myopathy. So you got to ask about pump function. Patient has a history of polysubstance abuse. Are they a drug user, right? IV drug user, right? So they have a high risk of endocarditis. Is there a valve issue here that we're thinking about? Should we be asking about systemic issues or valvulopathy or acute valvulopathy causing symptoms of shortness of breath, or subacute if there's some associated weight gain and volume retention. Coronary etiologies can be seen in 29-year-olds, not as often though, but that shouldn't cause as much weight gain, but can cause shortness of breath, and they tend to be more acute. So those are the things that I'm thinking about in terms of pump function, in terms of valves, in terms of a coronary etiology. You know, acute aortic injuries and things of that sort present mostly with chest pain, not often shortness of breath, but you could have a subacute event causing aortic insufficiency. You could think about that. Moving on to the lungs, again, a 29-year-old, okay, I'm thinking about more ischemic, more infectious symptoms. So I'm going to ask more about that rather than a primary lung pathology, such as pulmonary hypertension and things of that sort. That's going to be less likely. You know, you could have a history of polysubstance abuse. Are they, you know, been using a lot of alcohol for a long time? Is there a hepatic involvement? Are they gaining weight due to ascites and a short of breath because of that? You know, is there a primary renal thing? Or they have a nephrotic kind of a picture, right? So you're kind of working through all this in your head even before you go in there. And so I think it's important. I think add fun test to the source, going to the patient. I think we're spoiled by getting a report from the ER and a CT scan done and every lab done before they come up to you. But as you approach these patients, these are the things that you think about even before you get the objective data. Okay.
Okay. Thank you so much for going through that.
Absolutely.
I really appreciate it. I'll kind of give you a little bit more of the HPI, which will answer some of the questions that you posed about thinking about this one-liner. So I'll kind of start at this patient's baseline. 6 months ago, this patient was working in a factory. He works at a distribution plant that distributes hardware, where he was lifting heavy boxes and walking pretty much on his feet all day with no cardiopulmonary symptoms until about 2 months ago, when he developed some sharp chest pain and dyspnea on exertion, was admitted to an outside hospital in Southern Illinois, was found to have a EF at that time of 10 to 15% and a left heart cath with reportedly non-obstructive coronary arteries. I was discharged with a life vest and told to follow up with cardiology. He was outside the hospital for about 2 weeks and then readmitted to the same hospital for orthopnea, PND, dyspnea at rest, was given some IV diuresis and eventually started on midodrine and discharged again. He was out of the hospital for about a week this time and now is representing to the same hospital with palpitations and shortness of breath. Was found to develop cardiogenic shock with AFib with RVR, AKI, and elevated LFTs. Was transferred to the ICU, where he was started on a levo drip and amiodarone drip and briefly on CRRT. Was stabilized there for about 48 hours and then transferred to the BJH CCU, which is where you're meeting this patient.
That's fantastic. So already, you know, this patient's pretty sick, right? You know, you often think about individuals with heart failure, right? It's easy to say, oh, this patient has heart failure. We need to treat the acute issue and injury and insult and help stabilize them. But always ask the question, why? Why in a 29-year-old is there an EF of 10 to 15%, right? Ask those questions. Is that normal? Is that common? Do I commonly see 29 years old, not 29 years old with an EF of 10 to 15%? And the answer is no, right? So we already have a one-liner that said they have a history of polysubstance abuse. You know, methamphetamine-induced cardiomyopathy and other toxic metabolic etiologies of cardiomyopathy are common. That's something to keep in mind and think about. But it's important not to anchor on that either, right? History of diabetes, hypogonadism. Okay, is there an infiltrative process that's causing this? That's something that you think about as well, right? LFTs are elevated. Is this just shock liver, or is this cardiorenal process with the AKI and whatnot? But is there a primary hepatic etiology for this? That's also something to consider and think about. So those are the things that are going in my mind. Obviously, I want to make sure that this patient is stabilized and is on appropriate support. But I'm also thinking, okay, well, what is driving this? And I want to think about my next diagnostic workup to help delineate and enlighten me as to what those next steps are.
Okay, perfect. Yeah, so you're kind of balancing the competing priorities of hemodynamic stabilization and diagnosis for this patient when you see them. I'll give you a little bit more information about them. Some things we already talked about is their medical history of erectile dysfunction, hypogonadism. They have a chart history of type 2 diabetes, although when I reviewed this patient's chart, the last A1C I could see is 6.5, so relatively well controlled, not on any meds for that. And then this newly diagnosed HFrEF. No surgical history, a family history of a maternal grandmother who had an MI in her 80s, and then maternal aunt who died kind of all of a sudden in her 40s that he thinks is due to a heart attack, but could not be sure.
Okay.
No allergies. The only medications he was prescribed was the midodrine. He's been on this testosterone patch prescribed by his PCP for a few years, and then vitamin D supplementation, which apparently he read online was helpful for his health. He smoked a half pack a day for 15 years, drinks mostly beer and social occasions, uses methamphetamine 1 to 2 times a week and has for about 2 to 3 years, and then uses marijuana edibles once or twice per week and has for several years as well, and no IV drug use.
So there's a few things that bother me about this, right? That I can't just anchor onto methamphetamine use causing cardiomyopathy, right? Why is he on testosterone? He's really young, okay? He's requiring midodrine. That means his heart failure is really burnt out, or there may be something else going on that's potentially causing him to continually remain hypotensive. Is there, some degree of adrenal insufficiency here? And if so, why, right? Is there that kind of playing a role? And the whole diabetes thing, okay, what's his BMI? Like, why is his, A1C 6.5%? It's, kind of early onset for a type 2 diabetic. So those are the things that I'm thinking about. Really, I'm really leaning towards ruling out an infiltrative process at this point because I would be worried about something that's systemic, right? That's causing more than one problem, rather than putting it, pinning everything to methamphetamines at this time in terms of his heart failure.
Yeah. Given that and kind of what you're thinking, is there anything on review of systems or physical exam you'd be looking for?
Yeah, absolutely. I mean, I think one of the things I would think about is skin color. In terms of weight distribution and BMI. Blood pressures right now, he's obviously pretty sick and whatnot, so it's hard to delineate. Those would be kind of the big things that I would be kind of thinking about.
Okay. We'll go ahead and go to the review systems then. So no constitutional symptoms, really just positive for dyspnea on exertion and occasional dry cough. Recent onset palpitations really prior to this most recent admission, lower extremity edema, orthopnea, PND. Chest pain is largely resolved since that initial admission a few months ago, and then decreased urine output. No rashes, skin discoloration or changes, and then notable for depressed mood.
And no numbness, tingling. If you're thinking about paresthesias, other things, you're thinking about amyloid. And okay, all right, fantastic.
Okay. You've kind of gone through a lot of your thinking, so we can go ahead and move on unless you have any additional
absolutely.
thoughts.
No, that's perfect. That's the most important part of your, or I'd say second most after your history is your physical exam. Yep. So you have that next?
I do.
Perfect. We didn't plan this, guys. I promise. I didn't cheat.
So again, this patient's in the ICU. They've been stabilized a little bit at the outside hospital ICU prior to transfer, but they are on levo. Heart rate's in the 90s, respiratory rate's 19, satting 91% on room air, so requiring a little bit of oxygen, and then BMI of 19. Notably not in acute distress. Your cardiovascular exam is notable for irregular rhythm. 2 out of 6 early systolic murmur, best heard at the apex, JVD to the mandible when examined at 45 degrees. And then your kind of distal pulses are palpable and symmetric. There's mild bibasilar crackles on your pulmonary exam, and otherwise the abdominal scan, MSK exam are all pretty non-focal.
All right, just looking at the exam, obviously a little hypotensive. His BMI is not very high, it's 19. So again, this, it's interesting that he's diabetic with not a metabolic profile that I would think would be a patient with diabetes. Type 2, at least irregular. So he has a fib. Looks like his quite volume overloaded based on his exam. And then you've kind of talked about mildly depressed mood twice. So I wonder if that's a hint, but we'll get to that. So right now, okay, if I were to throw out a differential, right? I mean, with his BMI being as low as it is and having all these other comorbidities with hypogonadism and diabetes and whatnot, I'm really thinking now really infiltrative more so than methamphetamine use and things that come to mind like hemochromatosis, amyloid less likely, but those are the things that I'm thinking about right now.
Okay, perfect. I'll go ahead and give you some initial labs, and these would be the labs that the patient presented with, so about 48 hours ago, just for context.
Okay.
And what we're comparing the labs to would be when they were discharged about a week prior to this admission. Give everyone a chance to read these.
So end organ perfusion's bad. His lactate's elevated. You can see a significant elevation as creatinine. He's hyponatremic in addition to that. Again, a poor prognostic indicator. Your transaminases are in thousands, right? Kind of almost like a shock liver picture. When we see transaminitis due to a function of RV failure, you usually don't see it that high, but it's not the rule always, but that's pretty high. So I'm really worried about kind of his end organ perfusion. So probably a complex process, not only just volume overload, but also poor hepatic perfusion, shock liver, or could be in addition to a primary hepatotoxic process. So coags again with that INR would follow. And then the platelets, he's pretty thrombocytopenic. So that's an issue there too.
Okay. So kind of what you said earlier is you're weighing in your head, are these lab abnormalities all from this patient's kind of hemodynamic instability or shock, or does
Is
the
there
patient
another
have
primary process? Yeah.
primary pathology in their liver or kidney, for example?
Yeah.
Okay. It's not listed, but a TSH was also done, and that was normal.
Did you do a ferritin?
If that's
iron
something
studies?
you would like, we can get those later. So you want a ferritin and iron studies. Is there anything else you want?
Well, I mean, first, I mean, if he's hemodynamically stable, I'd get an echo, repeat an echo here, liver studies, because his liver is, shot. You'd kind of do the basic stuff, work up his liver, work up his kidney, and make sure that you're not missing anything else. I think the easiest thing to do while he's in the unit is at least start with ultrasound imaging. This could be done bedside while you hemodynamically stabilize him. And then, infectious evaluation. I'm not as, I don't think he had a leukocytosis. He didn't have fevers, chills. He didn't have anything of that sort. I'm sure he has some lines and things of that sort. So you're probably going to culture him before he comes in. Urine studies, yes, you can obtain some urine studies to see the underlying etiology of this, but it's probably going to be tubular injury with everything that's going on. Anemia workup, we kind of alluded to, maybe getting some studies, but it's fine. The infectious evaluation, we talked about cardiology, I think repeating an echo. I think a right heart cath here is a little challenging. His platelets are low, INR is bad, but given how sick he is, it's kind of a risk benefit deal here. You try to optimize the best you can and try to line them up so that you can help optimize the patient. May even need support, and that could potentially be challenging with this current hematologic state. I think that's kind of what I would be thinking through. I mean, I think we'd be getting a lot of this simultaneously.
Yeah.
But I think from an imaging standpoint, I'd start with at least an ultrasound, and then hopefully down the road, he may need a cardiac MR and potentially evaluate the liver if the ultrasound is concerning.
Perfect. Yeah, we'll start then with cardiology since you are a cardiologist.
Perfect.
And here's some kind of initial lab.
Great.
I don't admit
NT-proBNP fits the clinical picture, quite elevated. We know his coronaries were okay from prior, so I'm glad you're not activating the lab for me with that troponin count. I'm very thankful. And then A1C is quite elevated and his lipids are low. So, that could be a function of poor synthetic liver function too, is LDL and things of that sort being low.
Sure. I'll give you an EKG.
It's interesting. Okay, so you got, I have some fellows on the audience, Should I pull that card? Josh doesn't want to. Neural doesn't want to. You guys were chief residents, Matt, I feel bad because, I wouldn't do that to Matt, but maybe the prior chief residents. Who do we have here? He's pointing me somewhere. Puya's not paying attention for a very good reason. Do you want to help us out with this EKG? No, it's okay. No, I know, right? So this is the kind of relationship we have with our fellows. It's a plug for the cardiology fellowship program. So anyone interested in cardiology, please join us. All right. So first, we're thinking about, what's the rhythm? Okay. I see upright P waves, 1, 2, looks like it's sinus rhythm, but you have some extra beats here and there. So I see some premature, looks like PACs. And so that's, I think it's, sinus rhythm here, rates, these like kind of borderline tachycardic here, 300, about 100, between 150 and about 100 or so, a little over 100, depending on which interval you're looking at. There's some degree of irregularity. He has a little bit of a left axis shift. His QRS complexes are, kind of downward going. You have decent, you don't have really good R wave progression here. They kind of become upright in V5 and V6. So, there's definitely a shift there. You're not necessarily seeing Q waves anywhere. There's a small R deflection, but again, you don't have good R wave progression there. So saying that, yes, his heart is myopathic. But again, his QRS complexes are pretty large. The question being his BMI is 19. So could you use the criteria for LVH here? I think that's a question to be asked. Again, with this QRS complexes being, you can't totally rely on them given his BMI and things of that sort. So it'd be nice to see an echo image to see how thick his ventricle is, because I'm worried about infiltrated processes. Often if you have infiltrated processes, your QRS complexes, you don't expect them unless if it's LVH due to, say, aortic stenosis or hypertension where you have increased muscle mass, you're going to see larger QRS deflections. But here, it's a little odd because I'm thinking infiltrative and I'm seeing this, but his BMI is also 19. So it's interesting. Yeah. It'll be good to look at his echo.
Okay. Yeah, sinus rhythm with PACs. Does the activity kind of fit with your differential as well of infiltrated process?
Yeah, potentially. But again, patient has heart failure. There's, atrial enlargement, things of that sort you're thinking about. He went into AFib as well. His BNP is high. So you can have, atrial activity that's off, not just because he may have an infiltrated, it might be his hemodynamic status too.
Sure,
So,
sure. I do have an echo for you. These,
Okay.
we'll say these are bedside obtained.
Okay.
And we'll go ahead and play the parasternal long.
Yeah, the parasternal long in the top left corner. You can see the LV is quite dilated. It's not squeezing as well, right? The EF is probably around that 5 to 10% range. There's no color Doppler to see if there's any significant valve dysfunction. Again, LV is pretty dilated here as well. That's your short axis at the level of the pap muscles. Again, you're seeing that the LV is not squeezing as well. Again, kind of very weak, okay? Next, you got this apical four-chamber view. Again, your atria enlarged, your LV is dilated and hypocontractile there.
This is just the 5-chamber.
All right.
I'm wondering,
5-chamber, go ahead.
I'm wondering from like a phenotypic standpoint, and you're thinking about someone with a non-ischemic cardiomyopathy, does the phenotype on echo give you any sort of clue as to what could be the ultimate etiology of?
Yeah, no, that's a great question. I mean, often the one echo finding in infiltrative myopathies, often you see is amyloid. You see a very thick heart. You see the speckled architecture. You see apical sparing on strain pattern. That's kind of the pathognomonic for amyloid here. I'm not seeing really it's not that thick. I mean, it's thicker than I would expect it to be. It's not thinned out that I would expect in a dilated cardiomyopathy. So it's thicker than I would expect, but it's not as thick as I would expect in, say, a burnt out amyloid or something of that sort. So I'm still thinking it's not as thin that I would expect that this person has this dilated cardiomyopathy due to drug use and things of that sort. But it is slightly thicker than I would expect.
Okay.
So that thought still is ongoing as to is there something else going on?
Okay. I heard you ask for urine studies earlier, so we'll go ahead and do those. Here's your UA and UDS.
Okay, great. Positive for marijuana. Okay.
Okay. And then
you didn't want to pick on your program director? No.
Does this mean anything to you, Dr. Chang? Okay. Okay, great. Agreed. Okay. I heard maybe you were interested in some infectious.
The good thing to know is it doesn't have nephrotic range proteinuria. There's nothing like that. You don't think it's a primary renal etiology for this, where he's retaining fluid and things of that sort. We knew that already based on his clinical picture, but
okay. Okay. Would you send any infectious or rheumatologic workup other than just kind of standard cultures on this patient?
I don't know. I don't think I would. I'm not leaning towards it. I mean, you could send some inflammatory markers if you're really looking to see if there's any active inflammation, because you could be thinking of myocarditis. You could be thinking about infectious myocarditis, but you really didn't paint that picture for me. Mm-hmm. But for completeness' sake, it may not be unreasonable to send some inflammatory markers at least.
Sure. I'll go ahead and give you the infectious evaluation.
Well, I mean, you could do the hepatitis panel. Sorry.
Yeah.
Think of that. And HIV with his liver, but yes, sorry.
Yeah. I have VCV, EBV,
correct.
Tylenol level. Those things were also sent on the patient as well.
Okay.
Those were
so hepatic workup was unremarkable for that. Okay, great.
And then you asked for a ferritin level specifically. What would you be looking for?
I'm looking for hemochromatosis. Oh, okay, great. It's very high.
It's very high.
I mean, I think you threw me a softball with that one-liner, because I think there's not a lot of things in a 29-year-old that would cause that. And this is, it's really funny. I have to give Alan Braverman a shout out, because I was thinking about the differential for this, and I was like, yeah, it could be hemochromatosis. But so we went to a faculty dinner yesterday. This is how amazing he is. And I told him the one-liner. It's like, you know what it's going to be? It's going to be hemochromatosis. I'm like, that's what I was thinking. And I was like, so it's nice to be around greatness. It's so he was right on right away. So I'll give him credit for that. Shout out there for Alan. I'm sure he's watching. So that's what I think is going on.
Okay. Is there anything else that could cause these laboratory abnormalities?
Ferritin is an acute inflammatory state. You could see it elevated in acute inflammatory. So it's an acute inflammatory marker, but not at 150 K. Usually don't see it that high. And your iron level's high, your TSAT is high. So I think it kind of fits, but now maybe I could be completely off, and you're just throwing me off by giving me a really high ferritin number, and I'm gonna make a fool of myself, but that's okay. I'm okay doing that. Okay. But that would be very high for an acute phase reactant.
Yeah, maybe it's HLH.
Could be HLH.
Could be. Maybe I'm just messing with you.
But I'm not a hematologist, so you wouldn't do that to me.
Okay, I will say hematology was consulted on this patient at this time with these labs with concern for hemochromatosis, and they weren't sure.
Okay.
They weren't sure. But if you were going to try to confirm that diagnosis, what would you do?
I mean, I think either biopsy, liver, or because it would be hard, you know, with the current hematologic state. I mean, I think if he's, you know, it could get, I think there's liver elastography they can look at in terms of a fibrosis and whatnot. So they could look at an ultrasound of the liver. That's possible. That could be done bedside, or you could jump to an MRI. You could do a cardiac MRI or MRI of the liver, and then when able, you could potentially consider doing biopsy if it's non-diagnostic.
Okay, perfect. The primary teams did order some of those images that you requested. To go through them, I will invite Dr. Stacy Kim, one of our assistant professors of radiology with in the Department of Cardiothoracic Imaging, to come up and kind of walk through some images for us.
All right, so first we have the patient's cardiac MRI. I have some representative images here. We have two bright blood images here. I guess you can't see my mouse on the screen. Two bright blood images on the left-hand side that show that the heart is enlarged. The left ventricle is severely dilated with myocardial thinning, and the RV is mildly dilated, and the volumes were calculated in this patient, so that's where I get the severely dilated and the mildly dilated from. I don't have any cine images here to show you the function, but the LVEF was calculated to be 13%, and that was with global hypokinesis, so no regional or focal wall motion abnormality. And then the RVEF was calculated to be 26%. You'll also note on the bright blood images that the liver, shown on the bottom image there, has diffusely low signal. And then in the middle of the screen, I have two T1 map images. One is a very colorful color scale image, and then the other one is a corresponding black and white image. Those are used to characterize the myocardium, as opposed to looking at anatomy or function and that sort of thing. These are acquired pre-contrast, and for a 1.5 Tesla scanner, which is what this patient was scanned on, normal T1 map values for the myocardium are 1050 to about 1100. Values higher than 1100 mean things like scar, fibrosis, edema, something infiltrative like amyloid or sarcoid. And then values that are less than 900 mean either fat deposition or iron deposition. And the numbers are very tiny on this image, but they are all in the 700s. So the values are abnormally low. And then I have one late gadolinium enhancement image on the right side of the screen, and that just shows some very mild mid-myocardial enhancement at the level of the mid-interventricular septum. That's a pretty nonspecific finding, but in this patient with dilated cardiomyopathy, that can just represent a little bit of scarring. So in summary, we have a patient with dilated cardiomyopathy, severely reduced LVEF, also reduced RVEF, with diffusely low T1 map values throughout the left ventricular myocardium, and also low signal throughout the liver. So these findings are in keeping with iron deposition. Thank you. Okay, and then the patient has an abdomen MRI as well. I have two coronal haste images on the left side of the screen. Shows that the liver has a normal contour, so it's not shrunken, nodular. It doesn't look like a cirrhotic liver. There was no liver lesion. We do have severe iron deposition in the liver. As you can see, it's diffusely hypointense, and then there are special sequences on these liver MRIs that the body radiologist can use to quantify the amount of iron in the liver, and it was calculated to be 26.9 milligrams of iron per gram of tissue, and anything more than 15 is considered severe iron deposition. The patient has moderate splenomegaly, which you can see on that coronal image as well. That's nonspecific, but there's no iron deposition in the spleen. And then the two images in the middle of the screen and the two images on the right, Those are T1 weighted in-phase images and then R2 star images that show that there's severe iron deposition in the liver. There's also moderate iron deposition in the pancreas, no iron deposition in the spleen, and then there is partially imaged cardiomegaly with some increased signal on this R2 star map on the bottom of the right side of the screen that suggests some myocardial iron deposition as well, although that's incompletely evaluated on this exam and was better evaluated on the cardiac MR. So in summary, we have a patient with severe hepatic iron deposition, moderate pancreatic deposition, and then some partially imaged cardiomegaly with suggestion of mild myocardial iron deposition and no evidence of splenic iron deposition.
All right. Thank you so much, Dr. Kim. Okay, so you now have images that are maybe consistent with the diagnosis that you were thinking about for this patient.
Yep.
I'm wondering, kind of thinking back to your earlier discussion about the prioritizing, supporting the patient hemodynamically and then getting the diagnosis. Maybe you feel more comfortable with the diagnosis now. What would you be thinking if you're taking care of this patient about looking forward to supporting them hemodynamically and maybe helping them get what they need?
Yeah, it looks like they have, obviously I'll consult my partners in terms of the best course of management because it's, you saw the degree of iron deposition and there was multi-organ involvement and kind of understand what his prognosis would be based on treatment. Now, his cardiomyopathy, again, may not be completely reversible at this point, depending on how well he does with treatment. After acute management, ensuring that he's appropriately managed the best we can and treating the underlying process, it's going to be next steps in trying to delineate what the long-term implications and treatment plans will be for him. So I'd refer to my heart failure specialists to help support me in that. If they want to put an Impella in, I'm happy to help them now that his hematologic issues have sorted out.
And then my other question, is there any kind of genetic testing that you would?
Yeah, so it is an autosomal recessive trait. I think it's one of the more common ones. If I'm not mistaken, it's about 1 in 300 or so individuals who get it. So I think understanding, if he has any siblings or anything of that sort, I think understanding if there is a genetic test that comes back positive and then potentially testing siblings and being mindful of progeny if that's in the works.
Sure. Yeah. Mm-hmm.
But we have this history of diabetes, as you point out, for person, hypogonadism. Now we know that that's significant iron liver. Retrospectively, is there anything in your presentation or history that we could learn from that might be valuable in terms of picking up the patient earlier course of disease so that at the time of the patient already has had
Yeah, what a wonderful question. And I think this is why we do this, right? I think asking that question, why? Why in a 20-some-year-old? Yeah, it's great. I mean, this is kind of why, this is how we start. It's like, why does this patient have this? And when you guys are seeing these patients in co-clinic, right? If you have a young patient who it just doesn't fit, if it doesn't fit, it doesn't fit. Figure it out why it doesn't fit, right? And I think that's the important piece is why is this young person having multi-system involvement, whether with diabetes, hypogonadism, et cetera? Should we be thinking of something else? Should we be working this up? And being inquisitive about that and asking that is key. I think the last CPC I did, same thing. It was a young patient with a FEO crisis. But this person had hypertension for a prolonged period of time. It was brushed off to anxiety because that individual was a PhD student and whatnot. And they were saying, hey, it's burning. So we're going to chalk it up to that. But no, just thinking about, the process. And if it doesn't fit in terms of the demographics, the age and whatnot, to ask that second question, is there a driving process? So I'm sure there was a possibility. It's just that I think I fall in this trap too. We tend to anchor more often than not. And I think breaking away from that and asking why is important.
Okay. So now, just because we've kind of already talked about it, the final diagnosis is,
Apathy due to hemochromatosis.
right. Nice job. And I'll just want to go through the hospital course a little bit and do some teaching points about this patient. I think that was a wonderful presentation. So this patient did have some genetic testing sent. He was actually heterozygous for the most common genetic variant for hereditary hemochromatosis, which did not fit because this disease is autosomal recessive. But with the clinical picture, they presumed that there was some other genetic variant that this patient had that we do not commonly test for that interferes with iron regulation and absorption in our gut. During this admission, the patient was able to become hemodynamically stable. They got on PO diuretics. They got on some GDMT. Their ferritin, LFTs, and creatinine all improved. Heme saw them. Hepatology saw them. They had a good discharge plan to follow up with them, and the advanced heart failure team would plan for a pituitary MRI to look for iron deposition that may have been causing the hypogonadism symptoms. Unfortunately, the patient was readmitted about a month later to our CCU in fluid cardiogenic shock, requiring triple pressors. Speaking of, they actually did get a balloon pump that you put in. So you did participate in this patient's care. Yeah. Which went well, by the way. Yeah, no complications from that. Yeah. And ultimately was upgraded to an Impella. The advanced heart failure team was consulted, obviously, and they had a repeat echo, which showed torrential TR and severely dilated RV. So they thought this patient would not be a good candidate for an LVAD. They were discussed about their transplant candidacy and ultimately deemed to be not a transplant candidate due to his stimulant use. Hematology was following as well, and there was a discussion about whether phlebotomy, which is the mainstay of treatment for hemochromatosis, would have some benefit, but this patient was anemic and critically ill, and so that was not pursued, and chelation therapy would not have any effect on the iron that's already deposited in this patient's heart, liver, pancreas, and likely pituitary. So that was also not pursued, so there was really limited treatment options for this patient. Who ultimately transitioned to comfort care and passed in early 2024 in our CCU. A little bit more about hemochromatosis. It's obviously an iron overload problem. It's due to genetic mutations in hepcidin, which is a negative regulator of transporters that bring iron from our gut into our bloodstream. So low hepcidin means more transporters and more iron from our gut into our bloodstream. It presents kind of classically like this patient. This is a classic presentation of hemochromatosis, and the treatment is traditionally phlebotomy. And just a note on the genetics again. So there's this common genetic variant, that's the C282Y genetic variant that almost 80 to 100% of people who have clinical hemochromatosis are homozygous in that. There's one other less common gene, that's the H63D. That's seen in about 10% of people with clinical hereditary hemochromatosis. Our patient was positive for one copy of the C282Y and the wild type. So again, they were heterozygous, which did not fit with the kind of classic presentation of the genetics for hemochromatosis, but there are other non-HFE genes that can be mutated that have some impact on the expression of hepcidin or those transporters in our gut wall. And those patients who have those genetic variants typically present earlier. This patient was presumed to have those because he presented in his 20s. And patients typically who have those common genetic variants present in their 40s. And the penetrance is relatively low for expression of this disease as well. About 1 in 10 people of Northern European descent actually are carriers of this. So the genotype frequency is probably much more common. The penetrance in women who have the genotype for the disease is about 1% and about 30% in men. And again, typically presents in the 40s. Most people present in their 40s. But this was a really great case. I just want to say thank you to Dr. Thakker for coming and explain some excellent clinical reasoning. And thank you guys all for coming. Yeah. Thanks for coming. Appreciate it.
I was like, you gave me a nice one-liner.
Yeah.
So it's reading.
Good.